Welcome to the Pancreatic Cancer Action Network's webinar, The Role of Radiation Therapy in Pancreatic Cancer. My name is Sheila Bott, and I am the Manager of Scientific and Medical Affairs for the organization. At the Pancreatic Cancer Action Network, our goal is to give you hope through better resources so you can make informed decisions. Patient Central can provide free, personalized information on many topics, including pancreatic cancer specialists and treatment options. Contact Patient Central at 877-2-PanCAN or email patientcentral@pancan.org. I would also like to take this opportunity to thank our webinar sponsor, Ispen, and to thank our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Halozyme, Ispen, Janssen Oncology, Rafael Pharmaceuticals, TriSalus, and TYME. The webinar is scheduled for 60 minutes and includes a presentation followed by questions, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Joseph Herman is currently a professor and division head ad interim in the Department of Radiation Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Herman specializes in the treatment of pancreatic and hepatobiliary malignancies. He is a writing member for several guidelines committees, a member of the Scientific and Medical Advisory Board for the Pancreatic Cancer Action Network, and a member of the NIH Neuroendocrine and Pancreas Task Forces. His major areas of clinical and basic research involve identification of novel biomarkers and integration of stereotactic body radiation therapy with immunotherapy and targeted therapies. Dr. Herman, I will now turn the presentation over to you.
Okay, thank you. So the first thing that's important, I've noticed that when I see a lot of patients, they really haven't been educated on the anatomy of the pancreas and where their tumor is located. And so first and foremost, it's important. I think this is a great picture that really outlines the head of the pancreas, which you can see here. And then as you move to the body or the neck of the pancreas, and then the tail of the pancreas, it's important to understand, especially with radiation therapy, where your tumor lies because it can affect where you're going to have your toxicity. So although you can't see it here, the stomach kind of lies in this region. So body and tail tumors, when we're giving radiation, you have to be very mindful of how much filling there is in the stomach. So a lot of times we're going to have patients do simulation with an empty stomach so that the stomach is pulled away from the tumor. And then with regards to head tumors, we have to be obviously very worried about the duodenum, which is right, as you can see, extremely close to where the tumor is. And a lot of times, this proximity to the duodenum is going to influence what type of radiation we're going to be able to deliver, and I'll talk about that shortly. So, for example, if it's abutting or invading into the tumor, we're not going to be able to give high-dose, short-course therapy or it's going to be difficult because you essentially can't spare the bowel. But if it's further away, then we can typically give the high doses of radiation in a shorter period of time. In addition to that, it's important to understand the difference between arteries and veins. So as you can see in the red here, arteries are more challenging to remove surgically by the surgeon, whereas veins can be either partially resected or actually what we call reconstructed, where they can cut out above and below and then reconnect it. This is important because when you're understanding whether the tumor that you have is considered resectable, borderline resectable, or unresectable, a lot of the information is going to be related to the anatomy of where your tumor is located and where these structures are located in reference to your tumor. So when we look at the veins, when we think about staging, you'll hear that they talk about less than 180-degree involvement. And I just wanted to show you a couple pictures of this is what less than 180-degree involvement would be. This would be more than 180-degree involvement. And then obviously a deformity suggests that there's actually growth or invasion into the vessel that, again, could make it difficult for the surgeon to go in and remove it surgically and not leave behind any tumor. And again, it's important to note that veins can be reconstructed surgically or you could use grafts, et cetera, that can make it easier to remove the tumor in total. On the other hand, again, arteries, again, it's the same assessment in terms of the amount of involvement of the artery. But generally, when the tumor is invading more than 180-degree involvement, you can understand that it'd be difficult for the surgeon to go ahead and remove all the cancer away from the artery. And in some cases, the surgeon can remove the artery, but if they remove part of the artery or reconnect an artery, if that artery develops a blood clot or a complication, as you can imagine, it's taking oxygenated blood to that organ, and especially, for example, the liver, and that can cause major complications for the patient down the road. So the first thing to understand as you begin this voyage is, what stage am I? Am I resectable, which means that the surgeon doesn't really need any upfront therapy, that they can remove it. Borderline resectable, which means that it's abutting most of the vessels, or unresectable or locally advanced, which are typically used synonymously, which suggests that there's usually more than 180-degree involvement of the artery, or where the vein cannot be reconstructed. And then I'm going to talk a little bit about metastatic disease. Historically, we didn't talk about metastatic disease and radiation, but there's some exciting work being done where radiation may have a larger role. So as I mentioned, in a situation where a tumor is considered resectable, you could see the tumor right here. It's a hypodense area. And then you can see the vein, which is usually the larger vessel. This is superior mesenteric vein. And then this is the superior mesenteric artery. And you could see there's a clear plane. You could see a dark color between that, suggesting that there's no involvement. So by definition, this patient can undergo upfront surgery. On the other hand, when you have a similar situation where you have, again, a tumor here, but now you could see some fuzziness around the vessel, that suggests that there's at least 180-degree involvement here of that artery. And in that case, it's going to be a difficult situation for the surgeon to go in and remove it. So typically, we're going to want some chemotherapy and or radiation to try to sterilize that region, so that when the surgeon goes in to remove it, there's going to be ideally no cells left behind or no disease left behind. On the other hand, you can see this is a tumor that's completely encased by this artery. The tumor is completely encasing this artery. And if a surgeon tries to go in and remove this, it's almost impossible for the surgeon to not leave behind some cancer. And so therefore, that's considered to be more locally advanced. The challenge, though, is a lot of patients, it's not really cut and dry, and patients are going to fall somewhere between both of these other situations. And that's why it's really important to get evaluated by a high-volume multi-center study where multiple disciplines are evaluating the cancer. So just as a summary, if there's very little to no contact, it's considered resectable. If there's more than 180-degree involvement of usually especially the arterial structures, it's locally advanced. And then in the middle is going to fall in the borderline. And again, the space between the borderline and the locally advanced is the challenging area. Unfortunately, as we know, pancreatic cancer is becoming more and more prevalent, and we still have a lot of patients that die of the disease. And at this time, surgery is really the only potentially curative option, but not all patients who get surgery always do as well. And I think it's important to stress that surgery isn't always the answer, and in some cases, patients can do better without surgery. And we'll talk about that a little bit. But in general, with resection now, it's actually upwards of 2 to 3 years and even 4 years in some cases. And then in borderline resectable, if patients get upfront chemotherapy and radiation, it's going to average around 2 years. And then historically, the locally advanced or unresectable was considered to be more palliative, but that's changing. It used to be about a year, but now we're approaching 2 to 3 years in patients if they do well with upfront therapy. As mentioned, if you can have your case evaluated by a multidisciplinary team, I think there's a lot of value in that. That way you know that everybody is discussing your case in detail. And here's just a quick example of, historically, if you're being seen by a bunch of different practitioners over several weeks, it can take a long time to get started. Whereas if you could be seen in a day or a week or so by everyone, you can get a consensus opinion and be able to move ahead further with your treatment. So there's some words that are used as we think about radiation, and I'm just going to touch on these. First of all, adjuvant means usually after surgery, and radiation is considered when patients have node or margin positive resections, meaning that there's lymph nodes that have disease or that there's some cells left behind in the vessels that were left at the time of surgery or at the pancreatic margin. And I'm not going to get into this a lot, but there is what's called intraoperative radiation therapy, which can be given either at the time of surgery to try to prevent a recurrence after surgery, or at the time of surgery, if they can't remove the tumor, it can actually be used to give a boost of radiation to try to keep the cancer from growing back. In the neoadjuvant setting, it's where patients are given upfront therapy, and in commonplace is definitely chemotherapy, but in some cases, as I'll talk about, radiation therapy is given before surgery. Definitive is usually in the locally advanced or unresectable space, typically when patients are not surgical, and the goal is to give as high of a dose possible to keep the cancer stable as long as possible, but also balance quality of life. And then finally, oligometastatic or metastatic is loosely defined as really less than 5 tumors in the body, usually in the lung or the liver. And in these cases, as I'll talk about, there is a role potentially for radiation to treat some of these areas to try to slow down the pace of the disease. So the role of radiation has changed dramatically over the past couple of years. When I first started about 15 years ago, this is the type of radiation we gave, a very big field. We covered this large area after surgery. But then came intensity modulated radiation therapy, where we modulate every single beam. You can imagine, multiple beams coming from different directions and sort of combined to really center in one area, in one isocenter, as it's called. I think that by having multiple beams coming in, most of the radiation is focused on a much more defined area as opposed to the very big area. Also, each color here represents the dose of radiation that's delivered. So, for example, the yellow is 50% of the dose that I want to deliver. So let's say I want to deliver 50 gray to this area. This area here is going to get 25 gray, or half of the dose that I'm delivering to this area. The other thing we realize is that if we want to give a high dose, as I mentioned, because of the structures that are near it, the stomach and the small bowel, if I can freeze the tumor, so when patients breathe, the pancreas moves quite a bit, and I'll show you that in a minute. If we can actually control the breathing with what's called an active breathing control device, we can track the tumor or actually freeze the tumor in space and treat that area. In addition, we have what's called image-guided radiation therapy, or IGRT, and what we do is we endoscopically place little gold markers or little gold fiducials into the tumor, and that allows us to, with millimeter accuracy, really focus, almost like target practice, right into that area and make sure that we're hitting the right area every day. And what these new technologies have allowed us to do is really focus in and treat a very high dose right at the tumor, but limit the dose to the normal structures. And you can see now, if you compare this to what we used to do, it allows us to treat normal structures less, and therefore patients have less toxicity, and we can ideally get to a higher dose of radiation, which will lead to a more durable control. And I added the wording there for you, just as a reference. So just to give you a kind of more what's called a color wash picture, again, you can see that the red is the full dose region, the blue is a much lower dose, and with stereotactic radiation, now we could do 5 days of radiation, really focus into this area and allow us to really miss the luminal structures. You can see the duodenum right here. You can see the stomach right there. It allows us to kind of limit the dose to those regions. Whereas, again, historically, before we were able to use all these technologies, we're kind of spraying dose to a lot of other areas, and this is what would make patients sick. Here's an example of a patient that received stereotactic body radiation therapy. You can see that the dose is very focused to the tumor, but limiting the dose in the normal tissues around it. And then this is looking at total dose. You can see this is the dose of radiation. This is the volume of every one of these structures. So each line, we actually circle the structure, and it gives us a volume of that structure. So, for example, you can see that the tumor gets full dose of radiation, but each of these normal structures, such as the kidney, the stomach, is getting a much lower dose of radiation. And again, that leads to less toxicity. One thing that's important to recognize is you can get what's called heterogeneous dose. So, for example, I might prescribe, let's say I'm going to prescribe 40 gray. Gray is just a way we describe our treatment. So it's almost like milligrams of a medicine. But if we are treating 40 gray to this region right here, we can also say we want to treat the center core of the tumor to a higher dose, and we can make the beams of radiation give a much higher dose. You could see that parts of the tumor in here are getting above 40 gray, although the whole tumor is getting a certain dose. And this can be very important when we want to treat, let's say, a vessel to a much higher dose in order to help the surgeon make sure that there's a margin negative resection. But where the bowel is located, we could treat to a lower dose so that we don't hurt the bowel. So what does it look like when we actually do this? This is an example of what we would do. We would contour out the tumor, which is called the gross tumor volume, which is in red. We add a little bit of a margin around it for setup error, or if the patient moves a little bit during breath hold. And then you can see that we treat what's called the tumor vessel interface. We want to treat this to a much higher dose. And again, that's that dose that's going to help allow the surgeon to remove it with no margins. And then finally, we are going to contour or circle the normal tissues to allow us to really avoid, we want to tell our what's called our dosimetrist to really avoid this area right here and treat as much of the tumor as you can, but to miss or at least avoid the normal tissue to try to decrease toxicity. There's a lot of different machines. People will call me and say, well, should I get CyberKnife or should I do this form of treatment? There's a lot of different machines, and in general, these all deliver what's called photon radiation or X-ray beam radiation. They all work fairly well. They're slightly different, but they're all effective. One example I just want to show you is that when you breathe, you can move, the tumor can move quite a bit. And here's an example just showing when a patient's breathing, you can see that it's moving up and down. So that, again, that's why we really recommend using breath hold treatments so that we can freeze it in space. And then those little markers can be done to follow. This right here, just so you know, is a metal stent. That's what it looks like on imaging. And this is just an example of what it looks like when a patient is on the machine. This little tracer allows us to track the breathing motion of the patient. And then we have the patient take a deep breath and hold it, and we have them put the yellow bar and the blue bar. And then when the patient is frozen in space, we get a CT scan. And then what we do is I have a small video here of this. You can see that this is what's called the simulation scan. This is the scan that we get ready, that we use for radiation planning. It's with contrast. And then you have the scan here that this is the scan we take the day of the actual radiation treatment. And this allows us, the CT on rails as we call it, allows us to check every day to make sure that the patient is exactly where they need to be. And then with millimeter accuracy, we can deliver the radiation. And so this is CT, this is called onboard or CT on rail imaging that allows us to do it in real time. But there's also now MR guided radiation therapy. There's a couple different companies that are doing this, and this allows you to do I'll show you an example in a second of where you now have an MR machine that's built onto the radiation machine, and it allows you to look really, to be able to see the anatomy even a little bit better than you can with CT. The other thing is that in addition to photon treatment, there's what's called heavy particle, which is either protons or carbon. And what's unique about this is that if you look at photons, photons have a high exit radiation dose. So example is when you shine the radiation, it's going to go through the body and it's going to continue on. With heavy particles such as proton, when you deliver the radiation, it kind of just falls off. It's almost like you deliver it, and here's a good example. You can see that beyond the beam of radiation, there's no dose out here, right? So it's able to deliver like and almost drop it off into the tumor, as opposed to photon beam where you have to add more beams coming in from different directions, and you're still going to get some exit dose. So again, heavy particle allows you to drop it a little bit more right where you want it. And also in theory, there's some improvements in terms of the response of the tumor, in terms of how it kills the DNA of the tumor, although that's still being evaluated. Here's an example of just the kind of images that we can get now with MR, and you can see this is a breathing motion of a patient during MR, and I'll just quickly show you just a couple different dimensions. So it's just, I think what's really cool is that the technology is improving more and more, so that literally we can look right when we deliver the radiation now, we can see exactly where the tumor is, where the bowel is, and make sure that it allows us to give a much higher dose of radiation safer. And ideally, a higher dose is going to lead to better outcomes and better control. So to switch gears now a little bit to just focusing on what's called stereotactic body radiation therapy. So stereotactic body radiation therapy in general is given over 5 days. It's a much higher dose, and it's usually not given with chemotherapy. On the other hand, what I call standard radiation or chemoradiation is given over usually 25 or 28 days. In some cases, it's given even more than that. It's usually given with chemotherapy, and the chemotherapy is usually oral capecitabine or oral 5-FU. And when you compare and contrast these two, the SBRT, as I mentioned, allows you to do a little bit of a sharper gradient, a sharper fall off. Generally, there's less acute toxicity because you're not treating those normal structures. It's easier to give because it's only over a week. And it can also, in theory, be given with other modalities. I'm going to get into that, such as immunotherapy or targeted therapies, because you're giving it over a shorter period of time, and it's easier to mix it with other things. From a quality of life, there's no question. It's easier for patients. It's actually cheaper than standard chemoradiation. There's less immunosuppression, or what we call lymphopenia, so that's important if we're going to combine it with immunotherapy. In theory, the radiobiology, as we call it, is thought to be more favorable. It's thought to be a little bit more effective at killing the cancer cells than if we do it over 5 weeks. However, sometimes the anatomy, like I mentioned, if the tumor is right up against the bowel, we may not be able to do it over 5 days, and we have to extract it out. There may be a higher risk of late toxicity, but that's being evaluated. And again, if you're going to do this, you're generally going to treat a smaller area, so you're not going to be treating like a lot of the lymph nodes or other disease that may be outside of the pancreatic region. So some of the earlier data that's looked at this is a study that we did with Stanford and Sloan Kettering. And in this study, we basically, without getting into too much detail, we showed that stereotactic radiation led to as good of a survival with really equivalent toxicity to what you would see with 5 weeks of radiation. It wasn't a randomized study, but it was a single-arm study, multi-center, that showed that at least it was safe, and the results were as good as chemoradiation. And you can see here that the toxicity was reasonable. There was a few patients that had a fistula and ulcer, but these patients are usually patients where the tumor was growing into the bowel. And now that we don't treat those patients with stereo, typically at my institution, we don't see those toxicities. And then the quality of life was unchanged, suggesting that, again, it was very tolerable for patients. What was exciting about this is, several years ago, that we actually had unresectable, what we call locally advanced patients that actually did go to surgery. So that was real exciting for us from that perspective. In addition to that, there's been several other studies that have shown that there's essentially equivalence between SVRT and conventional radiation, and even this was a suggestion that stereotactic had a slightly better survival than chemoradiation. And then there's been multiple centers now that are looking at stereotactic radiation, and again, the results suggest that it's safe, and that we're still learning exactly what dose is needed and how to best do it, but there's been tons of improvement over the past couple of years. So next is sort of when we think about radiation in these different stages, it can get confusing. And you can see here that these are all the different combinations that are quote unquote reasonable based on standard guidelines. But what are the right ones for you? And I think that when we think about it, we like to break it into really two big groups. So first is a performance status of 0 and 1. These are patients that are fit for surgery. And performance status 2, or ECOG 2, are those that are generally unfit. These are going to be older patients who just really have other conditions, medical comorbidities, et cetera, or medical problems. So if they're fit, we generally recommend patients get up 4 to 6 months of chemotherapy. If they don't develop any metastatic disease, we then, if they do really well and have an incredible response, sometimes these patients are going to go right to surgery. On the other hand, surgeons typically are going to want us to do a little bit of radiation, either stereotactic or otherwise, and then try to get to surgery. And then, I'm not going to get into too much detail about maintenance chemotherapy and such, but, this is a kind of a hot topic right now as to what should patients get after the fact. On the other hand, if patients aren't good candidates for surgery, I still think there's a role of radiation to kind of palliate. So after a little bit of chemo, patients can tolerate now stereotactic very well. So stereotactic is very, very well tolerated, and I've actually treated a few 90-year-olds that have done quite well. So what about resectable disease? So when we think about resectable, the first thing is to break it into adjuvant and neoadjuvant. When we think about adjuvant disease, which is meaning that the patient has had surgery up front, meaning no upfront therapy, and then what do we do afterwards? Well, one thing is clear is that if a patient has surgery and does not have a negative margin, which means that there's R1 means that there's microscopic, R2 means that there's really gross disease left behind, these patients don't do well. So first and foremost, you want to ask your surgeon, do you think you're going to be able to get it all out? And if they say, well, I don't know, then you probably should get some upfront therapy first. Although this is about radiation, I just want everybody to be aware that this is an important study that came out recently. It was presented at ASCO. Basically, that modified FOLFIRINOX, which has been shown to be better than gemcitabine in metastatic disease, also has been shown to be better in the adjuvant setting without radiation even. But there's a national study that has been going on for about a decade now, and it's a little bit confusing because this study is the erlotinib arm has closed, but long and short of it, the question is they get upfront chemotherapy for 6 months and then randomized to radiation or no radiation. The study's ongoing. It's hard to say. The fact that it's still open suggests that there may be some benefit with giving radiation after surgery, but it still needs to be determined. So one thing that we're looking at now is standard chemoradiation after surgery can take a long time. It may not always sterilize the margins. We don't know if it's really beneficial. But we still know that local progression is still a major problem. And we know that even at autopsy, there's 30% of patients who die of pancreas cancer never have metastatic disease. So local recurrence is still an issue. So the question is, can we squeeze in 5 days of radiation after surgery? And one thing that we did is we wanted to know if we were going to give 5 days of radiation, we have to give it focused. So we looked back and said, okay, where have patients recurred after surgery? And all these little dots represent areas of recurrence. So what we did is we essentially just came up with a volume that we would cover these areas, and we mapped out exactly how that would be done. And we did a trial. This is at Hopkins, and it closed a couple years ago. We're in the process of publishing the results. But in this study, right after surgery, patients got vaccine, 5 days of radiation, and then went on to FOLFIRINOX for 6 months. And then they went on to more GVACs and vaccines. And so I think this is one way that we can squeeze in radiation, before chemotherapy to try to prevent local recurrence down the road. And then there's a study out of Georgetown that's open right now that's slightly different. What they're doing is doing a little bit of chemo after surgery, squeezing in 5 days of radiation, and then keep going with chemotherapy. So this is just a slight switch from that, but this is open for enrollment. So what if we have resectable patients who believe in general, why don't we still, even if they're resectable, why don't we give upfront chemotherapy or radiation? And the reason for doing that is we know that if you give upfront chemotherapy and radiation, it increases the likelihood of getting a margin negative resection, especially in what we call borderline patients. It avoids unnecessary surgery in those so if a patient develops metastatic disease after two months of chemo, we know it's a good thing that we didn't put them through a big surgery. It minimizes delays, and it's easier for patients to get therapy before surgery than after surgery. It allows us to treat smaller areas, and it has less toxicity because of that. So there's pretty good data. This is, again, another study that just came out in the last year that looked at surgery up front versus chemo and chemoradiation followed by surgery. And the study was pretty impressive in the sense that you could see the median overall survival was much better in those patients who got chemotherapy and radiation up front versus those that went through surgery directly. So I would say that at this point, getting at least chemotherapy and then, and at least based on this study, some radiation is probably the standard of care for resectable patients. So switching gears, borderline again is where we have 180-degree involvement or less. And I think the first thing that's important is patients will always say, well, Dr. Herman, we gave chemotherapy and it shrunk a little bit. You gave radiation and it didn't shrink. And I think it's important to stress that most tumors don't shrink after chemotherapy and radiation, but it doesn't mean that they didn't respond. And what I mean by that is that a lot of times it looks the same as it did before, but then the surgeon takes it out and there's no disease left behind. Other times it looks the same and there's a lot of disease left behind. So we need better ways other than just CT scans to evaluate these tumors moving forward. This is a busy slide, but it just shows a lot of studies that have shown that if you give in borderline resectable, where it's up against the vessels, if you give upfront chemotherapy and radiation, that you're going to get about a 90% margin negative resection rate. And if you get through all the therapy, your survival is going to be similar to that of patients who had upfront surgery. So what's some of the data out there when you combine chemotherapy, stereotactic radiation or radiation in patients with locally advanced or borderline resectable? And this is a study out of Johns Hopkins where patients received chemotherapy plus or minus SBRT, about half of them that got radiation, and then either went to surgery or didn't. And you can see that in this patient population, the median survival is approaching around 3 years in those who were able to get all the therapy. On the other hand, those that didn't get surgery, you could see it was less. What's interesting is that even with all this therapy, local progression is still common. So it suggests that we still need to be more aggressive with local therapy, but also we need to be more aggressive with distant therapy or systemic therapy. So this trial is now closed. This is the study that was looking at whether there's a benefit with adding radiation to FOLFIRINOX in patients with borderline resectable treatment. And we're currently evaluating the data. So we're going to be looking at this. This wasn't really powered to look at a quote unquote significant difference between the two, but it's going to at least teach us sort of more about what the role of radiation is, specifically stereotactic radiation is, which is again 5 days in this patient population. And I would say that this is roughly how most patients are being treated today off of any protocol. So the next thing is, now switching gears, we've been talking historically about just how we give radiation in general. But what if we get smarter and we can start saying, what can we add to radiation to make it more effective? So interestingly, losartan is a medication that's been around a long time, an angiotensin inhibitor, which it was shown in a retrospective study that interestingly, patients who were on this drug did better after surgery than those who weren't. And so it started raising the question, like, why is that? So a lot of work with Ted Hong and others and the Steele Lab at Mass General started finding that if you add losartan, it actually can decrease the fibrotic nature of the tumor and allow chemotherapy to flow better to the tumor, and ideally you can get a better response. And if you get a better response, in theory, it should make you a better candidate for surgery. And also, by shrinking the tumor, you're pulling it away from the bowel, and it can actually also decrease toxicity. But in addition to that, if we give radiation to the tumor, we can ideally bust up the tumor, bust up the cells, release these proteins and these antigens that also could make the tumor more susceptible to immunotherapy. Sadly, we know right now that if you just add immunotherapy with chemotherapy for pancreatic cancer, it doesn't look to be very effective in most cases. But we're looking to say, okay, if we can add radiation, can we enhance the response to the immunotherapy? So this is our Stand Up to Cancer trial that we're doing with other locations. This is open. It's currently open. And it's looking at several different approaches, but the backbone is FOLFIRINOX plus stereotactic radiation given over 5 or 6 days, followed by surgery. And then you can see that they were adding in losartan, or we're adding in losartan, and we're also adding nivolumab, which is a immunotherapy. So we're trying to understand that if we add losartan and immunotherapy to radiation, can we get a better response than just having FOLFIRINOX and radiation? Another trial that's looking at similar principles this is a study out of Hopkins that I think is probably almost closed, and it's slightly the same, but it's FOLFIRINOX, and then there's stereotactic radiation with the GVAX, and again with immunotherapy. And then if patients are unresectable, they obviously continue on immunotherapy. If they're resectable, they go to surgery. And either way, there's a lot to be learned from these types of trials. So now, that was actually a locally advanced trial, but just trying to keep it consistent. Now moving to, again, locally advanced or unresectable is where the tumor is invading or involving more than 180-degree involvement of the important arteries, such as the celiac artery or the superior mesenteric artery, or it's not able to be, or the venous involvement is so extreme that the surgeon cannot do a reconstruction. So historically, this is a trial, this is the LAP-07 trial. This is one of the historic trials that asked the question, does standard chemoradiation improve survival after chemotherapy? And so these patients all received chemotherapy up front, and then they were randomized to receive radiation or no radiation. Again, erlotinib really didn't pan out to be effective. And you can see here, there's no survival advantage. So with this, a lot of the medical oncologists say, well, there's really no benefit with radiation in pancreatic cancer. But it's important to stress that only 60% of patients even made it to the point of getting radiation. In addition to that, what we found is that there was a significant local control benefit with radiation. And since this only included gemcitabine, we think that with FOLFIRINOX and with gemabraxane, so with better chemotherapy, that local control is going to become more and more important. In addition, we found that some of these patients were able to go to surgery, but there were not many. Only a couple % of patients made it to surgery. So in theory, if we have better chemo, better radiation, perhaps we can do better with this patient population. Also, what changed around this time is we never really would resect or remove patients that had what we call locally advanced or unresectable, and that's why it's called unresectable. But what we found is that in certain circumstances, after comprehensive multidisciplinary review, if patients had at least 4 months of chemotherapy and no metastases, if they had a good performance status and not a lot of other comorbidities, they had stable CA19-9 and were technically resectable, which means the surgeon thinks they could remove it. Even if there was more than 180-degree involvement of that artery, they say, I think I can get it out. And then ideally, you want to do it less than 12 weeks after radiation, because after 12 weeks, it starts becoming more fibrotic and it can be hard for the surgeon to remove it. So again, at Hopkins, we looked at our patients, I'm not there now, but when I was there, the locally advanced patients. So you could see that out of the 461 locally advanced patients, about 20% of them were able to have surgery. And it doesn't seem like a lot, but keep in mind, historically, it was maybe 1 or 2% of patients with locally advanced disease would go to surgery. And what's exciting is that you could see that of those patients with locally advanced disease that made it to surgery after chemo and radiation, the median survival approaches 3 years. So, and even those that didn't go to surgery had a median survival of almost 2 years. So the take home here is that, again, well-selected patients can still have a great outcome even if they have unresectable disease. So this is one study that's being done currently at Hopkins, at MD Anderson, Stanford, and some other locations where now doing a randomization after FOLFIRINOX, randomizing patients to radiation or no radiation with stereotactic radiation, and then trying to see if these patients are going to be able to be surgically resected. But in reality, what we're learning is that if we want to, quote unquote, sterilize a tumor, if we want to prevent the recurrence of a tumor, we have to get to a higher dose of radiation than we've been given historically. And so we know now that if we're going to give, let's say, 5 days of radiation, we need to get to 50 gray. If we're going to give 25 days of radiation, we need to get to 75 gray. These are the doses we want to get to, but with the anatomy, we can't always get there. So I'm not going to go over this slide. I'm going to leave it as a reference, but I think this is really helpful for those that are trying to understand, what are they a candidate for? Are they going to be able to get the 5 days of radiation? Can they get it in 15 days or can they get it in 30 days? And then also this shows you whether, is chemotherapy given or not? And then in general, also I kind of mapped out here a little bit, what are the toxicities and also what are some of the time and benefits? So I think this is just a good reference to understand if you're in this situation, these are some good questions to ask the radiation oncologist as to what regimen would be best for you. And feeding into this is some retrospective data out of Sloan Kettering, where they took a similar approach as I just outlined. And what they did is that if the tumor was less than a centimeter from the GI tract, they would give, if it was really close, they would do 25 days of radiation. If it was greater than a centimeter, they would do 15 days of radiation and get it to this dose. And if it was greater than 2 centimeters away, then they could do it in 5 days of radiation. And based on this, the data looks very promising. So with the higher doses of radiation, you can see that the survival is much more favorable than it was historically. And a lot of these patients, just so you know, did not go to surgery. So again, stressing that you don't have to go to surgery to have a good outcome. But again, we're still trying to understand which patients should or should not go to surgery moving forward. However, there are still risks. So you can see here, with limited follow-up, there's still around 10% of patients that still have some toxicities. So it's just, again, we have to be mindful and we're still learning as to how do we escalate the dose, but with less toxicity. So now to switch gears a little bit, what if we can add a radiation protector or a modulator that can protect the bowel while we give the radiation treatment? So this is a drug called Galera that was shown in head and neck cancer to protect the oral mucosa. And again, without getting into too much detail, it's a randomized study where we're looking at dose escalation of radiation with or without this protective drug, and then looking at the outcomes. And what we did in this trial is this trial is currently open. And what we're doing is saying, okay, we're going to try to get as high of a dose as we can in this yellow region, and then give as high of a dose to the tumor, but still limit dose to the duodenum while giving this radioprotector. And so this trial is open, currently being evaluated. It's still very early, but in the first patient, what we did is you could see, again, very focused dose to the tumor here in the center, and the patient was scoped before and after treatment. And you can see, at least in this one case, there was no damage to the bowel despite a very high dose of radiation being given. As I mentioned before about carbon and heavy ions, the other thing is, what if we give heavy ions? Maybe because it's thought to be more effective, we don't have to give as high of a dose. So you can see here, this is the other way that we can give a higher dose of radiation, and at least suggest that with chemotherapy and heavy ions, you can have a better outcome. The other thing is, as I mentioned, you can use MRI, and if you're using MRI and you're looking very carefully where you're treating, if you give a high dose of radiation, it seems to be resulting in better outcomes. And again, this is a trial that's currently open using MRI-guided radiation to give a higher dose. Also, we could use what's called PARP inhibitors. So as you know, the study just came out in metastatic patients that patients that had a BRCA mutation seem to do better if they, with a PARP inhibitor. So this is a smaller study out of Cedars-Sinai that showed that if you give radiation with a PARP inhibitor and gemcitabine, that patients that had tumors that expressed what we'll call DNA repair pathway genes, that they tend to have a better outcome with the combination therapy than if they did not have this profile. So again, it just goes to show that maybe we could give better drugs and we don't have to go to as high of a dose of radiation. I have a couple slides just on recurrent disease. Patients will say, well, I already had radiation. They say, I can't get more radiation. I'm not going to go into a lot of detail, but just to show you that, yes, in general, you can. There's a number of publications showing that, that you can re-irradiate, and that, again, being very careful with better image guidance, that we can go to a higher dose. And in general, if you're going to get re-irradiation, it does suggest if you get maintenance chemotherapy with the radiation, you're going to do better. And then finally, what about metastatic and oligometastatic disease? We wrote an editorial about this, saying that maybe we should be more aggressive with surgery, radiation, and even ablation with interventional radiology to try to get rid of some of metastatic disease. It's something that should be ideally done on a clinical trial, and there is a trial at MD Anderson looking, it's called the Extend trial. It's looking at a lot of different tumors, but essentially, if you have 5 or less tumors, in general, you're basically going to be a candidate for treating all of your disease with surgery, radiation, or interventional radiology to try to essentially ablate all disease and see if that results in a better outcome than just doing standard chemotherapy alone. But at the end of the day, what really matters is, how do we select patients? How do we know what patient is going to benefit from radiation? And so there's a lot of efforts right now looking at biomarkers, looking at tumor and liquid biomarkers, looking at PET, and then also looking at CT, even just looking at like how the texture looks on a CT scan, and understanding, how do we decide who's going to benefit from radiation and what kind of radiation? And here's just a quick example of a PET scan. You could see that there was PET avidity before radiation. After radiation, it went away. And then this patient went to surgery and had no disease left behind. On the other hand, a patient who has residual PET avidity after radiation maybe shouldn't go to surgery and should get additional therapies. Also, just looking at clinical biomarkers, this is a really nice study out of Mayo, where they looked at different factors. So, for example, if they got at least 6 months of chemo, had a CA19-9 response to radiation, and then also had a complete response, that they did better than those who didn't. So again, try to add different clinical factors together with biomarkers to understand what's the next path that you should take as a patient. So in summary, this is kind of what I use as the kind of overall, approach. Again, surgery is not always the best outcome, but again, as of right now, it seems to be the most durable as we look at other options. I highly recommend looking at the ASTRO guidelines, which were just came out. And these are, I think, really effective ways to sort of learn about the different types of radiation and understand what the standard of care should be. And so in summary, there's a lot of technologies out there that allow us to give higher doses of radiation with less toxicity. But again, every tumor is different. So it's important to sit down with your surgeon, your medical oncologist, radiation oncologist, and say, I want to see my tumor. I want to understand, is it close to the bowel? Is it close to the stomach? What am I even a candidate for radiation? Ideally, if we can get to a higher dose, we know it's going to be better. There's multiple approaches to do this. I do think that just like surgery, there are some benefits to going to high volume centers where they have more experience. But again, I think it's becoming more and more common that most centers have the technologies. As mentioned, you could look at radioprotectors. We're waiting for the alliance results to come back. And then finally, just again, looking at how do we use radiation with all these different, like with PARP inhibitors, with immunotherapy, to try to enhance, different therapies to not only help with the local issue, but even maybe help protect patients against subsequent systemic recurrence. But again, we need better biomarkers moving forward. And I did summarize this again for your own reference in terms of how radiation, the different effects and approaches to radiation. I listed also, this is a little bit outdated, but this is just a list of a lot of the trials that are using stereotactic radiation right now. I have one here, and I have another one here. And then it takes a village. It really takes a ton of experts to work together to get these outcomes, to do the research, et cetera. I'm a huge advocate of PanCAN. Get out there, please continue to support. It's also fun to bring to kids. I added this, I asked the patient, what should everybody think about? And she added some things here. Again, I won't keep it up too long, but you can take a look at it later on. At the end of the day, I think be your own advocate is very important. And then again, people who were kind enough to share slides with me through the process. So I think we have some time. Sorry for the beginning, I apologize, but I think we still have some time for questions, and I'm happy to stay over a little bit if everybody else is okay with it.
Thank you, Dr. Herman, for a very informative presentation. As you mentioned, at this time we do have a few questions. So the first question is, okay, although not common, what side effects can patients expect with SBRT?
Yeah, good question. So acute side effects, the most common I find is the first day of radiation, patients will have a little bit of nausea. So if you are prone to nausea, I would highly recommend going ahead and just taking Zofran or Compazine or some antiemetic prophylactically. In addition to that, patients describe just sometimes just feeling a little bit, they describe sometimes a little bit of a pain after a couple of days, and that could be just like kind of a brief inflammatory process. But other than that, it's actually very well tolerated. Patients typically can do their normal activities. The biggest toxicity is more the late toxicity. So when the tumor is really close to the stomach or duodenum, no matter how perfect we are, you're still going to get some dose of those regions. And we know that if you start approaching 30 to 35 gray to the normal structures, that's where you could start getting some duodenal ulceration or gastric ulceration. And so for that reason, we highly recommend patients go on usually some sort of protected, like Protonix or Prilosec or, one of those drugs to kind of help decrease stomach acids and protect the bowel. And if you start having some of those pains or discomforts, Terafate is also another thing to take to kind of cover the area. But if it persists, I highly recommend that you get another endoscopy just to take a look at things. And sometimes if there's small vessel bleeding, et cetera, then the endoscopist can take care of it. And then finally, if you start feeling really tired, that's a suggestion that you could be having a bleed. And I would highly recommend going and get a blood test to make sure that you're not anemic. And if you're anemic, make sure you go quickly to a center that can do an endoscopy and that can evaluate you. It's very rare nowadays, but again, as we start dose escalating, I am a little concerned that we're going to start seeing, more of this. So it's important that patients are educated about those risks.
Wonderful, thank you. The next question is, after receiving radiation therapy, does one have to be careful to stay away from loved ones?
No, with all the forms of radiation that I discussed, they're all X-ray radiation. There are some trials looking at different kinds of radiation that's injected directly into the tumor. I didn't get into that, but in those cases, there are some other precautions. But no, there's no risks, no limitations. You can definitely hug your kids or grandkids. There's no problems with that.
Wonderful, thank you. The next question is, are there currently any national guidelines that suggest patients should receive radiation at high volume centers?
It's a good question. I'm trying to jog my memory in the ASTRO guidelines if we said that, but I think it just depends. I think that if you're going to get standard chemoradiation, there's a little bit more forgiveness in that setting, and for that reason, I think that those can generally be delivered anywhere. I think for stereotactic radiation, or when you start getting to these higher doses that we've discussed, I think then you have to ask the harder questions. You have to say, what kind of machines do you have? Do you have what's called image guidance? Do you have a way of looking at my tumor in real time? Or are you going to use fiducial markers, which are little gold seeds that you could track it? Or how many of these cases have you done? What kind of experience do you have? I think it is getting more complicated. And so I think with standard dose stereotactic radiation that you're going to give in the preoperative setting, generally, I think that, again, if they've done, at least 10 cases, I think they're pretty, usually pretty good. But I think just like surgery, it's getting more and more complicated. And so, and it's plus, since a lot of times it can be done in 5 or 15 days nowadays for most patients, then if you can financially and such, it may be worth traveling to a higher volume center.
Okay, great. Thank you for sharing that. The next question is, what would you say to patients who have metastatic disease and want to incorporate radiation to their care?
Yeah, I think first and foremost, you want to look at the trajectory. So if you're taking chemotherapy and it's progressing, that's not the time to do radiation. If it's progressing in one area, let me take a step back. If you have, let's say you have 5 lesions and all 5 are growing on chemotherapy, that's not the time to do it. You need to get on another systemic therapy that's at least going to control some of the disease, or if it's progressing elsewhere, right? But if, let's say you have 5 lesions and you've been on chemotherapy for 6 months and one area is growing, to me, that's the perfect scenario where giving, stereotactic to that region in, 3 to 5 days or even 1 day now, it's easy to do, it's safe, and or if it's very peripheral, interventional radiology now, although there's not a lot of data, they can go in and do ablation, RFA ablation, et cetera, and do that. That's a little more invasive, obviously, than doing stereo. But again, it's doable. So I think that, and or like I mentioned, the trial that I mentioned, the Extend trial, is where you have patients who are stable on chemotherapy or, again, have progression in maybe 1 or 2 areas. That's where we're trying to treat all of the areas aggressively to try to keep it from coming back, or at least really kind of control the disease down the road. But the reality is, with this disease, it does spread elsewhere. So we're just not sure if it's always going to help. But again, I would say that, keep asking questions. Every time you see your oncologist, just say, is there anything else I should be doing? And do you think radiation has a role? And at least that would start that conversation.
Wonderful. Thank you for that answer. The next question is, can you speak a little bit about SBRT, or proton versus photon treatment to the lungs?
Wow. Okay. So, I would say that the vast majority of metastatic disease, maybe I'll just talk briefly about proton versus photon, and then I can get to the lung specifically. The benefit of protons in general are that you can give a higher dose with less beams of radiation, and by definition, you get a better fall off. So for a good example of this would be that if you have a lateral lesion, if you have a lesion that's like really close to your ribs in your liver, that's kind of a perfect scenario to give proton therapy, because you can radiate just that part and you're not going to get much dose to the center part of the liver. On the other hand, if you have a tumor that's in the center of the liver, where you have a lot of breathing motion, and you're going to potentially, you're not going to be able, when you're doing heavy particle, it's harder to bend the beams of radiation and target them. So it's kind of, think of it, that's why it's called heavy ions. It's kind of harder to sort of form those beams. So you're going to get sort of probably more scatter dose actually to the rest of the liver. Whereas with photon radiation, you could use 10 or 15 beams of radiation. And even though you're going to get a little bit more scatter around the outside, you can bend the radiation a little bit better right to the central region. So I guess the best way to put it is it really depends on the shape of the lesion, depends on the location of the lesion. And then also the other big difference is that with photon radiation, we can do MR or CT guided radiation. With a lot of proton machines, you don't have, the imaging is not as good. So you're not able to see the tumor, and you can't see the normal structures very well. So one more really quick example is that if the tumor is close to the bowel, proton is not going to be probably as good, and photon will be better. If it's away from bowel and lateralized, proton is going to probably be better than photon. And then for the lung, you can kind of think of it the same way. If it's lateralized, proton's probably as good. But again, with lung, the other thing is that the beam with protons, the proton beam may not be as predictable as it goes through the lung and goes through air. So again, it gets complicated. So I would just say that it's important to go see an expert that focuses on both and have your specific case be discussed.
Perfect, thank you. And at this time, we do have time for one more question, and it is that it was mentioned during the presentation that radiation generally does not shrink the tumor. So what is the best way to evaluate the effectiveness of a 25-day course of radiation therapy, and when should that effectiveness be evaluated?
Yeah, I think it's a really good question. And so some of the things that are being evaluated right now is Dr. Coy at MD Anderson is looking at what we call radiomics, or looking at texture analysis. So for example, looking at a CT scan, depending on if the tumor has a sharp edge within the pancreas versus a more blurred edge, that it suggests that it may have a specific outcome in terms of, its response to chemotherapy, its ability to respond to therapy, and whether they'd be a good surgical candidate, et cetera. In addition to that, MRI advanced, where MRI can give us a better sense of is there viable cells left behind, and then PET imaging or functional imaging, if there's what we call SB or residual uptake after radiation, that would assess there's some residual disease behind, it's gone, but the message that are played is about response. One person tried to squeeze one more question. One person asked, how do I know based on CA19-9 and or let's say PET, when is a good time to assess response? So one thing is if you check PET or CA19-9 prior to really, so if you check CA19-9 or PET sooner than 8 weeks after radiation, what you might be seeing is due to inflammation or irritation. So you really want to wait around at least 8 weeks before you're assessing true response to both PET or CA19-9 numbers. That's going to, and it's not always exactly correct, but it's important to mention that if you get CA19-9 or PET too early or MR too early, what you're seeing could be inflammation, and it's difficult to ascertain whether it was a good outcome or a bad outcome.
Thank you, Doctor. At this time, we would like to thank Dr. Herman for his presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted, and your patience is appreciated. Once again, we would also like to thank our webinar sponsor, Ispen, and our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Halozyme, Ispen, Janssen Oncology, Rafael Pharmaceuticals, TriSalus, and TYME. A survey will pop up once you leave the session today. Please take a moment to share your feedback. If you have questions, please contact Patient Central at 877-2-PANCAN and ask to speak with an associate. This concludes the webinar. Thank you.
Thank you.